Welcome back to This Week in Pulmonary and Critical Care Medicine. I'm your host, Aladdin Sagar. Every week, we break down new studies that matter for your bedside decisions, clearly, quickly, and without fluff. Today's episode covers 4 important areas: the true national impact of lung cancer screening, a randomized comparison of auto-titrating versus fixed CPAP in obesity hypoventilation syndrome with severe OSA, long-term risks following episodes of acute kidney injury, and we close with a detailed review on the evolution of CFTR triple modulator therapy. As always, this is for education only, not medical advice. All article links are available in the description below. Let's get into the evidence. Published in JAMA this month, this population-level modeling study by Bandy and colleagues examined a simple but essential question. How many lives are we actually saving with lung cancer screening at current national uptake? The U.S. Preventive Services Task Force expanded eligibility in 2021, but real-world screening remains low, roughly 9 to 31% in state-level data. Until now, we lacked a truly representative national estimate. The team used NHIS-based smoking histories linked to contemporary mortality data and modern stage shift assumptions seen in screening cohorts. They modeled 2 scenarios: current estimated uptake nationwide and an idealized world of full 100% screening adherence. The model incorporated modern treatment distributions, life table survival, and competing risks, producing a realistic simulation of U.S. smoking cohorts. The numbers are striking. At current estimated national screening uptake, they calculated that approximately 14,800 lung cancer deaths are prevented each year, translating into around 185,000 life years gained annually. These benefits occur despite the fact that national screening uptake remains far below ideal levels. In the 100% uptake scenario, the model predicts around 52,000 deaths prevented per year, with nearly 650,000 life years gained. That contrast, 14,800 versus 52,000 deaths, is the clearest quantification yet of the enormous gap between evidence and implementation. The study also examined demographic differentials. Screening benefits were proportionally highest among individuals aged 60 to 74, and the life years gained were greatest in those entering screening early in the eligibility window. If implemented equitably, screening would yield major benefits for populations with historically higher smoking intensity but lower healthcare access, including Black Americans, a point the authors emphasize as both a public health opportunity and an ethical imperative. The editorial perspective underscores the challenge. The U.S. has strong guidelines, validated mortality reduction evidence from NLST and Nelson, and now clear national modeling confirming substantial preventable mortality. But without system-level redesign, primary care prompts, and improved referral pathways, the majority of eligible individuals will continue to miss out. From a bedside standpoint, this paper reinforces the need for proactive identification of eligible patients. Every clinician who sees smokers or former smokers should consider screening workflows as part of routine preventive care. For hospital-based pulmonologists, the transition from inpatient consults to outpatient screening pipelines can meaningfully shift population mortality. The takeaway is simple. U.S. lung cancer screening is saving lives, but we're leaving tens of thousands more on the table. Scaling screening is not just a guideline task, it's an opportunity to prevent death on a national scale. Published in Respirology, this pilot randomized non-inferiority trial by Zheng and colleagues tackled a practical and clinically important question. Can auto-titrating CPAP be used safely and effectively in patients with obesity hypoventilation syndrome and severe OSA? These patients represent a phenotype in which the core pathology is alveolar hypoventilation, a physiology not always addressed by APAP algorithms. The trial enrolled 28 participants out of 84 screens, all with OHS plus severe OSA, with a mean BMI of 54, baseline PaCO2 of 49, and AHI around 88 events per hour. Participants were randomized to APAP or fixed CPAP for 3 months. The study was not powered for definitive conclusions. The authors targeted 44 for feasibility and estimated that 82 would be required for confirmatory testing, but the data still provide important comparative insight. The primary outcome was change in PaCO2. Both groups improved, but fixed CPAP produced a more consistent effect, minus 5.7 millimeters of mercury versus minus 4.1 millimeters of mercury with APAP. The between-group mean difference of minus 1.7 millimeters of mercury crossed both 0 and the non-inferiority margin, meaning APAP's non-inferiority could not be established. Importantly, the editorial by Bahamam reinforces this physiological point. APAP algorithms respond to airflow limitation and snoring, not to rising CO2 or sustained nocturnal hypoxemia. For a disorder defined by hypoventilation, that mismatch may matter. Adherence patterns favored fixed CPAP. Patients assigned to APAP had lower nightly use, more dropouts, and lower delivered pressures than their in-lab titration levels, a finding noted in the editorial as a potential signal of undertreatment. Quality of life improvements followed a similar pattern. Epworth scores improved in both groups, but functional measures improved only under fixed CPAP. As a pilot study, this trial remains constructive rather than conclusive. It highlights recruitment challenges, shows that both treatments reduce PaCO2, but also indicates that fixed CPAP remains the more reliable early-phase therapy. The editorial takes this one step further. Given the physiologic profile of OHS, pressure stability may simply be more important than algorithmic responsiveness. At the bedside, the message is straightforward. For OHS with severe OSA, fixed CPAP should remain first line. APAP can be used as a transitional bridge when needed, but requires close follow-up, attention to PaCO2 trends, and early conversion if undertreatment is suspected. Published in Critical Care Medicine, this systematic review and meta-analysis by Frasili and colleagues addressed one of the most important survivorship questions in critical care. What happens to patients after they survive an episode of AKI? The acute mortality burden of AKI is well known, but the long-term risks have been debated. The authors included 14 matched cohort studies encompassing more than 1,058,000 participants. All studies compared patients who experienced and survived a defined episode of AKI with matched controls who did not have AKI, with a minimum follow-up of at least 1 year. Across pooled data, long-term mortality was significantly higher in the AKI group, 26.4% versus 17.6%, yielding a relative risk of 1.42. The risk of requiring chronic dialysis more than doubled at 4.5% versus 2.0%, and progression to chronic kidney disease was also substantially more common, 51.5% versus 37.3%. These numbers clearly demonstrate that AKI is not a transient phenomenon, but rather a sentinel event in a patient's long-term health trajectory. Even after recovery of creatinine, these patients carry a markedly elevated risk of death, dialysis, and CKD progression, stressing the need for structured outpatient follow-up, something that still remains absent in many systems. The authors highlight notable heterogeneity, variations in definitions of AKI, lack of uniform post-discharge monitoring, and differences in comorbidity adjustment. Yet despite these differences, the signal remained consistent. AKI creates long-term physiologic vulnerability. From a practical standpoint, we should regard AKI in the ICU as a chronic disease risk marker. This meta-analysis supports integrating kidney health follow-up into survivorship pathways, with attention to nephrotoxins, blood pressure control, proteinuria screening, and patient education. We closed today's episode with an in-depth review published in the European Respiratory Journal, summarizing the evolution and future direction of CFTR modulator triple therapy. Burgel and Mall provide a comprehensive overview of how these therapies, particularly elexacaftor, tezacaftor, ivacaftor, or ETI, have transformed the landscape of cystic fibrosis care. The review begins with the pathogenesis. Cystic fibrosis arises from pathogenic variants of the CFTR gene, producing defective chloride and bicarbonate transport. Historically, treatment focused on symptomatic management, airway clearance, antibiotics, nutritional support, and transplantation. The emergence of CFTR modulators, potentiators, and correctors introduced a mechanism-targeted era. ETI was a turning point. In Phase 3 trials, ETI reduced sweat chloride by 40 to 50 millimoles per liter, improved FEV1 within days, reduced exacerbations, increased BMI, and improved quality of life. Real-world studies confirmed these effects in broader populations, including those with advanced disease. Imaging studies, CT and MRI, even demonstrated reversal of mucus plugging and stabilization or reversal of cylindrical bronchiectasis, a remarkable finding for a disease once considered structurally irreversible. One major development covered in detail is the ability to extend ETI to people without the F508 deletion variant. Initially limited to common genotypes, ETI has now expanded through a combination of FDA flexibility, in vitro data, and large real-world compassionate use programs, such as the French initiative. Responsiveness has now been documented for 531 variants, while around 957 variants, mostly true Class I mutations, remain non-responsive. Under the expanded 2025 EMA label, ETI can be prescribed to nearly 95% of people with CF. The article also highlights the arrival of vanzacaftor, tezacaftor, doidavacaftor, or VTD, a once-daily triple combination shown to be non-inferior to ETI in regards to FEV1, with a small improvement in sweat chloride. Whether stable ETI responders should switch is still unclear. The authors emphasize a crucial point. Even with highly effective modulators, persistent low-grade inflammation, chronic bacterial infection, and structural airway damage may limit the complete normalization of lung function. This aligns with real-world data showing that sweat chloride normalization does not always correlate with FEV1 gains, suggesting that earlier treatment may be key to preventing irreversible airway remodeling. Future directions include expanding variant responsiveness, improving access, and developing nucleic acid-based therapies such as mRNA and gene replacement, capable of restoring CFTR function even in those with Class I null mutations, the remaining group not helped by modulators. This review captures a field in transition. Cystic fibrosis is no longer uniformly progressive, but the journey toward complete correction for all variants and all patients remains ongoing. That wraps up this week's episode of This Week in Pulmonary and Critical Care Medicine. As always, thanks for spending a few minutes staying updated with the evidence that actually affects your practice. These studies aren't just academic. They shift how we screen, how we treat, and how we think about long-term outcomes for our patients. If you found this useful, consider following the channel, sharing the episode with a colleague, or bringing one of today's papers to your next team discussion. Small, consistent updates compound over the year, and that's exactly what this series is designed for. All the article links, figures, and infographics are in the description. I'll see you next week for another round of data, interpretation, and real-world clinical insight. Take care and stay curious.